TopMedTalk.
Hi, it's Desiree Chappell here and the TopMedTalk team. I hope you're staying safe during these times. We wanted to say thank you for downloading TopMedTalk. This piece is not specific to the COVID-19 crisis, but we are covering it daily. If you want more of that information, you can find it on TopMedTalk.com. Now, in the meantime, we are continuing to champion perioperative medicine like we always have done. And we're working with our academic partners as the crisis continues to bring you our normal scheduled content. We also want to say thank you to our sponsors, specifically Edwards Life Sciences, for their generous support. I hope you enjoy this podcast.
And on today's Top Med Talk, we're going to have a piece taken from the 20th Current Controversies in Anaesthesia and Perioperative Medicine Conference, held in Dingle by EBPOM. Don't forget, of course, you want more details on this podcast. Full show notes are available on TopMedTalk.com. Have a listen.
It's a delight to welcome our first speaker, Ross Kerridge, anaesthetist and associate professor in Newcastle, Australia. It's always an absolute joy listening to Ross's presentations, some of the most warm and thoughtful presentations I think I've heard at Dingle and other conferences. I think it's fair to say Ross has probably been suggesting how we could or should do perioperative medicine for the best part of about 20 years, and I think other places are now finally starting to get the idea. But our next speaker, Sol Aronson, who's a professor of anesthesiology from Duke, as it must be pronounced, where he's also executive vice chairman. He's also the lead for EBPOM USA, so he's very well placed to give us a picture on perioperative medicine from the US standpoint. It's a pleasure to welcome friend, colleague and mentor from Southampton, Mike Grocott, who amongst other roles is the chair of the perioperative medicine group at the Royal College of Anaesthetists, which in effect means he's entirely responsible for delivering POM within the UK, so no pressure. Mike has been known to say, quote, I'm all over it like a rash, so that's fine. We'll take some questions from the floor. I think we've either got mics or not, so we'll get you to shout out. I'll just kick off by asking each of the presenters. It strikes me that a key part of the success of perioperative medicine actually working on the ground is around the integration piece, really. And I think there are so many stakeholders and there are so many work streams going on. How do we ensure that actually this looks like a joined up bit of work to patients and doesn't stay in little silos? Any volunteers?
One thing is, I think you do it on a case-by-case basis. If we worry about there being a standard model at the coalface for how anaesthetists and surgeons and physicians and everyone else works together, I don't think there ever will be one. There are surgeries, so head and neck surgery, typically, in my experience, the surgeons are incredibly focused on the whole journey. They have long cases, so few patients, and so they're all over the nutrition and the smoking cessation and everything else. They probably don't need perioperative physicians. And there are other extremes, and I'm not going to take a pop at the orthopods because there is actually an orthopaedic surgeon in the audience, or there was earlier in the week, and he's feeling a bit bruised. But typically, the orthopods, we have high volume, relatively low complexity procedures in terms of the perioperative care. I'm not interested and are delighted when we take over. And then there's a whole spectrum in the middle. So I think the coalface model has to depend on the types of surgery, the individuals involved. Some folk are more or less interested, and be based around doing the right thing for the patient.
I think it's got to be, within the hospital there will be some groups that will get it and others that won't, and it's got to be local solutions, and each hospital will be different too. But I think promulgating that general vision that of legitimising the idea that the traditional way of doing surgery isn't working, that you've got to have a system for pulling it all together. And whoever actually runs that and is the core person on the ground doesn't really matter, as long as that you've got to work out the solution that works for you.
I would just add, obviously we're early in our curve to understand that. One of the things that we've tried to do, sometimes very successfully, sometimes with less success, is we are agnostic to specialists. When we have something we call POET, another acronym, it's the Perioperative Enhancement Team. it's warm and fuzzy, and everybody can identify with that. And there's no shout out to any one particular area being more relevant than the other. It's a group of people who have a common interest in just enhancing the value of the perioperative journey. We have hematologists on the team, we have neurologists on the team, I have internists on the team, I have geriatricians on the team, and everyone is invited if they have an idea that is worth hearing to sort of move that ball down the road. And it's a complex journey. It's not just medicine, though that's a core part of it. It's also implementation science. And for that, we also have finance in the room, and we have operation expertise in the room. And I have a 2-hour meeting every Monday. It's a steering committee where we literally just review things that we've launched, things that we're thinking about launching, crazy ideas that are just twinkles in our eye. But it's a free meeting for anybody to come to.
I just wonder if we obviously talk a lot about POM leadership and who's taking responsibility for those patients. I also think as we've looked at POM, we realise there's these groups of basically administrative staff that seem to have a fantastic overview of the patient journey and actually unwittingly wield a lot of power in terms of what that patient pathway looks like. I just wonder if we actually need to perhaps worry less about who's leading and actually just develop this kind of army of good administrative staff members that are actually good at taking that overview and actually gluing everything together so that the patient experience is right.
So I'm going to jump in and just say I strongly agree with that point of view. I think we're lucky in that we out of the box adapted that point of view, and it's been invaluable. I cannot imagine having had the successes that we've had or plan to manage the gaps that we've identified without having that competency in the room.
Ross?
Yes, but.
Yes, but.
Yes, and. I'm being coached about.
That's right.
Never say that.
How's it going?
Yes, and I think you also need to build that. Everybody needs to understand that even if they're enacting decisions and acting at a higher level than they used to, that there is someone that they can fall or flick the case to sort things out when things get really difficult or get really sticky. And something magical happens when you turn about 50 and your hair goes grey, and all of a sudden people treat you with respect. And and when things go really bad and you walk into the room with 3 or 4 other people and all the eyes are on you. But those people are really, obviously I've been in that situation a few times, but I think having people who are prepared to take that role is really important.
I think a really important element of your question was the pathway word, because in some respects you can define us with surgery and 1 or 2 other specialties as quite distinct from other medical specialties in that we're all about pathways. And so Sol's analogy of the take-off, flight, landing, which we've traditionally thought of as sort of induction of anaesthesia, sleep, wake up, actually works with contemplation of surgery to full recovery. And it's a different type of engagement with the patient than the chronic ill health doctors who have the very well-informed patients. It's a different relationship and a different pattern, and actually thinking about ourselves as pathway doctors and healthcare providers may be important.
Just to sort of harness, if you will, all the opinions to be, essentially the same expression. Smoking cessation is a population health issue that obviously has great impact on the patients that we see in the perioperative domain. That chronic relapsing disease doesn't go away, and what we do before they are having surgery is not a hard stop. In other words, we have a system right now where I have clinics all throughout the triangle, all throughout a 3-county area around Duke Hospital, and we're engaging with primary care physicians to stand up more, and those are all feeder groups from once we identify that need to touch that patient's issue. So I do think as a physician with a focused expertise in perioperative medicine, as we heretofore have defined it, not to respect that broader if you will, breadth of competencies, just limits our ability to do awesome things. And it's not to say that there's not a point of resolution when there's a cognitive, responsible difference of opinion. But I think you have to bring smart people into the room to make you better.
Ollie, Ross, Southampton, been waiting a little while.
So do you see this initiative as being something that could be truly global? How do you see all the work that's been done in Australia and America and the UK and other places kind of translating itself or being adaptable for obviously low and middle income countries? Inevitably I'm going to ask this because there are discussion this morning in my area of interest, but clearly this is stuff that could make an enormous difference to the kind of fire that is basically raging out there. We're in our city, everything's not too bad where we are, and it's pretty bad out there. And how do you see engaging? Have you presumably been approached by leaders in other countries who have their own institutions where they want to set this up for their high level stuff, but how do you see that working for kind of across the kind of low and middle income kind of type areas?
Ross, yeah.
Thanks for asking that, because I think that's a really interesting discussion. And my understanding, I had some exposure to less developed health situations, very young, and virtually nothing since. But my understanding from my reading is that the same messages apply, that there is a lot of preventable morbidity, mortality and costs associated with poor patient preparation and poor post-operative care. And it's seen as a low-value area. The surgeons tend to focus on what's going on in the operating theatre, and then the patients are falling apart on the wards, same as they are for us, albeit with different resource implications. But I think if we can get that message out there, and to some extent that question about do you train medical anaesthetists or medical anaesthesia providers, maybe we need to have medical perioperative specialists, regardless of who's actually in the operating theatre doing the procedure. And it rings bells very clearly with the experience of an Australian hero surgeon called Fred Hollows, who was an ophthalmic surgeon. But famously, he worked in Nepal and in Eritrea, and I'm not sure whether it was exactly where it was, but he realised that he shouldn't bother doing the cataract surgery because he was much better off supervising the clinics and setting up the systems, and literally trained non-nursing, non-technical, virtually kids straight out of school, generally younger women because they've got finer dexterity to do the actual cataract surgery. He said that wasn't the difficult thing. The overall system was more important for his charisma and expertise and all that. And I think getting out this message that perioperative medicine is a paradigm that applies very much even in resource-constrained situations is a very important thing. So.
It's a really interesting question, not just for its direct surface implications, but as Ross was answering it, I was actually thinking that obviously you have, it's situational and conditional, and you have to appreciate the priorities and establish a way to find those priorities and begin to chisel away at change. And a big bang isn't always feasible. But it's also a cultural transformation. And I was thinking, though you compared the States or Australia or the UK to less developed, if you will, regions of the world, I would argue within the United States there are institutions and hospitals that are very comfortable and able to, if you will, take that sort of bold leap. And there are institutions that are scratching and clawing to survive. And it's not even an national sort of analogy, but it's a regional one. And so what we've done to teach those other programs that aren't willing to have the vision or able to have the vision to take that leap is just to do their own internal sort of gap analysis, their own soul searching of where can you begin to implement change, and then build off of those small victories. And it would be the same answer I would have for the more international perspective that you just described.
the basic principles so shared decision making and improving, altering adverse health behaviours, managing comorbidities before elective surgery, and reliable, consistent care after surgery. It doesn't really matter who does them or what your exact system is, but the principles, I think, are still useful, and we've tended to focus on the procedure and maybe sometimes forget the penumbra.
Any other questions from the floor? Ollie?
I just wanted to ask, do you think the value proposition for perioperative medicine has been sufficiently made? Because my impression, certainly into the local institutions where I work, is that the main barriers to setting up a good perioperative medicine service are lack of resources and lack of money. So if you say to managers, we'd like to set up a more comprehensive perioperative service that will include more of our high-risk surgical population, the response is, well, who's going to pay for it? That needs more staff, it needs more resources, and there's not a sufficient evidence base to persuade them that will save money in the long run. Do you think that's something that perioperative medicine needs to address a bit more? My impression from you, Sol, was that that's a case that's kind of accepted in the States.
Well, it's not accepted. It was argued compellingly, and so it's a really important question because we are in that frame of reference where value has to be demonstrated. The argument I would make, the argument I have made, and the argument I continue to make is the easy wins are those areas where you can, in a first order sort of cost accounting model, tease out a contribution margin. If you take care of a patient and you send them to another specialist who's currently being able to receive some remuneration for what they do and perhaps even get paid for a procedure that's associated with that. There's a technical fee and there's a professional fee, and that's cost accounting, contribution margin, and that's very easy to do, and of course we do that, and that's really boring and not the answer. But we do it. The real answer is to address the reality that we're evolving to a risk-based, value-based economy for healthcare. Here's $10. If you can do it for 9, keep 1. If you can do it for 11, I'm sorry. And that's why we're in such a, I think, very interesting place right now. So it's not contribution margin accounting, it's cost avoidance accounting. And so you have to make the case, and you can do this. It's a very difficult, it's much more complex and a difficult calculus, but you have to do the cost avoidance calculation. And that's where you show the value proposition. We are in a state right now where the transformation to risk has accelerated very, very quickly, crazy fast. And it's competitive, as the free market would, have us live with. And we as an institution are realizing we have to change the way we do things. Because whereas in the past you could get paid for the plane that crashed, now you have to eat that. And so we're very motivated to make sure that plane doesn't land until the wheels are down.
Ross, you're shaking your head.
There's just, I'm in awe of things like this. I think I've just heard an MBA in the space of 2 minutes. But the overall thing, I think you're right. I think the message hasn't got out there. And perhaps, well, certainly in Australia, I'm not sure about it's probably in the NHS from what I've seen as well. It has been implemented at a local level, and people have seen, by making this deal about doing this, then we can bring in most patients on the day, and that's been easy. But I think getting the higher level bureaucracy and health economists to understand what it's all about, I don't think we've done that well. And certainly one of the things that the college in Australia is doing is a pretty high-level health economic analysis as a foundation for getting that message out there. And if you like, the target audience isn't the hospital business managers at a local level. It is at a higher level than that. So at the government levels, at mid-government levels, high government levels, and for the health insurers, so that they start putting the pressure on the hospitals to, look, have you sorted this out at a local level? And reinforcing the message.
So our context, the bundled payments is about where you're getting to at the moment. I know capitation may come, our context in terms of healthcare funding is moving towards true capitation, i.e. Here, Surrey have £1 billion and just sort it out. So everything, public, social, social care, primary care, secondary care, is all in the same basket. We're not there yet, but the experiments are heading in that direction. And so the avoidance of ineffective surgery is a massive win, because you're spending a lot of money achieving nothing or potentially adding cost. The nudges that we can do, because primary care is so overwhelmed that many patients essentially engage with us or perioperative care as their specialist physician for the first time. So the nudges around chronic disease management, diabetes, anemia, atrial fibrillation, etc., I think are enormous. And the prehabilitation, long-term behavioural change, and that impact on population health are all potentially massive. At the moment, the shared decision-making is the easy win because that works at an institutional level, but the others work at a system level, and that's where I think we're going. And I think it'll be a relatively easy win. And so, certainly at the moment, the STPs are they're all over perioperative medicine.
So I'm going to defer any further comments and discussions to a nice cup of tea. I'd like to thank you. Join me in thanking all our speakers this afternoon.
It's Desiree Chappell here. Just a quick reminder, subscribe to TopMedTalk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.